Hi, and welcome to Town Hall number 4. Today we are talking about hearing screening. We originally had on the docket vision and hearing screening, but we could not find a speaker for vision. So we are really lucky that we have a very professional hearing speaker today. But if anyone has a contact for a vision speaker, please email me. We are trying to get a vision speaker for next month's town hall. Our town hall originally next month was EMT communication and handoff, but our EMT friends are doing their own professional development series and are unavailable in that time frame. So we are hoping to find a vision speaker for next month to talk about vision screening. Without further ado, today we have Tracy Hinck here, and she is a graduate of the University of Vermont for her Bachelor's of Arts. And then she went out to California and completed her Master's of Science at Cal State San Francisco. She worked in the Bay Area for 23 years, and then she loved Vermont so much she moved back in 2015. She's a duly licensed audiologist and speech-language pathologist in both New Hampshire and Vermont, and is currently employed as the program supervisor for the DHHDB Educational Services Program at the University of Vermont Medical Center. Tracy serves on the board for the Vermont Deaf, Hard of Hearing and Deaf Blind Advisory Council. She is passionate about improving the lives of children with communication challenges. When Tracy is not working, she's enjoying time with her husband, 2 teenage daughters, and 14 pets. Yeah, you heard that right, 14 pets. Tracy and her family also volunteer for the Lucy Mackenzie Humane Society. I just want to do a little bit of housekeeping. Tracy is going to take questions as her presentation goes on. And so if you have a question pertinent to the slide that she's talking about, if you want to raise your hand, we can call on you. Or if you want to put your questions in the chat, if it's pertinent to the slide, I will let her know that there's a question for the slide. And if it's not pertinent to the slide and it's just a general question, then we'll save it till the end. So without further ado, Tracy, thank you so much for being here today, and we're really excited for your presentation.
Thank you, Becca. Thank you for the great introduction. Hi, I'm glad everyone is here. I'm going to go ahead and share my screen. So I understand that everyone here is really interested in hearing healthcare. I'm going to talk to you today about hearing health and education, kind of the impact that hearing challenges have on kids' development and education, and then also about hearing screenings. Due to the pandemic, I understand that hearing screenings kind of took a back seat for all the other things that that everyone was doing in the nursing field. And so it's nice to know that that's going to come back into play. So this is sort of my housekeeping. Sometimes things don't work exactly as we hope in the world of virtual presentation. So just please let me know if you can't hear a video, let Clayton know, let me know. And if you do have a question, go ahead and stop me. I'm happy to address them as we go through the presentation. Just a little agenda, and we can deviate from this. It's just a guide. What is normal hearing? What is typical hearing that we kind of all take for granted? What is hearing loss? What are the levels, different levels of hearing? What is educational audiology versus clinical audiology? What is the impact on education and development when a child has a hearing challenge? What kind of technology is available for students? Sometimes nurses are responsible for that technology in schools, and accommodations. Oftentimes we have 504 plans, and the school nurse is the case manager for those 504 students that have equipment. Hearing conservation. What kind of hearing conservation programs are happening in Vermont schools or part of outreach programs through the hospital? hearing screenings, what are they? What are the guidelines? What are the Vermont guidelines? We have some new guidelines from 2017 for older kids and higher frequencies. And why are we doing that? What are the suggested protocols? There are a couple suggested protocols, but I just am going to kind of stick to Vermont's. And then, why are we looking in their ears? What are we looking for besides a foreign object? What else are we looking for in their equipment? A lot of the times you're responsible for, ordering new equipment. I understand a lot of schools got new audiologic equipment for their screenings. And then just some conclusions and questions at the end. So what is normal hearing or typical hearing levels? I always find this really fascinating. It happens, very quickly. Sound travels, through your pinna kind of collects sound through the air. It travels through the ear canal. It vibrates the eardrum. It makes the three smallest bones in your body move together. And the last bone in that chain of small bones is connected to the window, the oval window in the cochlea. And in the cochlea, there's fluid. And that fluid gets pushed from those three little bones, and it moves the fluid in like a shearing action against hair cells. And then those hair cells spark the nerve. And so I always find this fascinating, and a lot of teachers do when I do these presentations for school staff. And sometimes they take this to their science class, that, hearing is so interesting. It goes from acoustic energy to mechanical energy to hydraulic energy to electrical energy. And it happens really, really quickly. So we hear through different like modalities. There's air conduction, which is what I just described, sound coming through the air. And then there's also bone conduction. So if you were to scratch your head, you're the only one that can hear that. So that's a way of sort of vibrating bones in your head that transmits sound. And that's called bone conduction. So sometimes if you are listening to yourself on an audio recording, you might think, gosh, I sound different, or I sound funny, or did I have a cold that day? That's because when you're talking, you're hearing your voice mostly through bone conduction and a little bit of air conduction. And when you're listening to an audio source, you're just mostly listening through air conduction. And how does, this kind of comes into play when we talk about hearing loss, right? Because there's different things that can happen in the auditory system that have significant impact on kids' development and learning language. So this is a little video that kind of goes through that process of hearing.
Sound waves entering the ear travel through the external auditory canal before striking the eardrum and causing it to vibrate. The eardrum is connected to the malleus, one of three small bones of the middle ear. Also called the hammer, it transmits sound vibrations to the incus, which passes them to the stapes. The stapes pushes in and out against the structure called the oval window. This action is passed on to the cochlea, a fluid-filled snail-like structure that contains the organ of Corti, the organ for hearing. It consists of tiny hair cells that line the cochlea. These cells translate vibrations into electrical impulses that are carried to the brain by sensory nerves. In this cut view, you can see the organ of Corti with its 4 rows of hair cells. There is an inner row on the left and 3 outer rows on the right. Let's watch this process in action. First, the stapes rocks against the oval window. This transmits waves of sound through the cochlear fluid, sending the organ of Corti into motion. Fibers near the upper end of the cochlea resonate to lower frequency sound. Those near the oval window respond to higher frequencies.
So hearing loss, education, developmental impact, and educational audiology. I stuck educational audiology in here a few times. Again, it's sort of one of my passions. A lot of times it's confusing about what happens at the clinic when an audiologist is testing hearing, and then what happens in the educational environment or perhaps the home environment to support school teams, children, and families with a child that has hearing challenges. So there's different kinds of hearing loss. There's different degrees, configurations, and different types. You can have, normal hearing at some frequencies, a mild hearing loss at others, minimal hearing loss, moderate to severe, and severe to profound. And so, sometimes when you see mild or minimal, a lot of times people assume that it's not significant, but it really is significant. And we're going to learn more about that in a little bit. It can be high frequencies. It can be a cookie bite configuration where perhaps some of the mid frequencies are affected in the hearing. It can be sloping, so normal high frequencies, and then it slowly progresses. It can be precipitous, so someone can have normal hearing in the low frequencies, and then it can really drop off in the highs. And it can also be a low frequency hearing loss. It can be unilateral, so one ear, bilateral, or both. It can be conductive, so permanent or fluctuating. So when we talked about bone conduction, that's a conductive type hearing loss. So when our kids have fluid, our little kids, even some of our school age kids, they have fluid in their ears. It can be infected, or it also can be not infected, and that causes a minimal to mild conductive type hearing loss. It's very similar as if you plug your ears. That's basically how that child is walking around at school. So they can hear you, but they're missing critical information, critical parts of speech sounds, and it's very fatiguing for them to listen, even though it's a minimal to mild hearing loss and maybe only on one ear. It can also there also can be permanent conductive hearing loss. So atresia, microtia, where, the ear canal didn't form. There can be, malformations of the ossicular chain. And then also can be sensory neural hearing loss. It can be cochlear or retrocochlear. And then it can be a mix of conductive and sensory neural. There's another type of hearing challenge called auditory neuropathy spectrum disorder. And what this means is the cochlea is actually okay, but when the sound gets through the cochlea in the transmission to the auditory cortex, there's a dyssynchrony. So hair cells, the hair cells are working, but the nerves aren't firing in a synchronous way. And what this causes is fluctuations in the clarity. A lot of people think hearing loss is a loss of volume, but there's actually a lot more to it. Is there distortion at certain frequencies? And with auditory neuropathy, there's a lot of distortion. And so kids with auditory neuropathy spectrum disorder really present differently than maybe a child with sensory neural or conductive hearing loss. So you might get an audiology report with an audiogram in it. Your audiogram might not look as pretty as this one. So oftentimes it's a printout. You'll see maybe some scribbles, especially for a younger child. What you're really looking for is, what frequencies are affected. So anything between 0 and 15 for kids is considered within normal limits. Otolaryngologists consider anything above 25 to be within normal limits. In educational audiology, we really look at 15 and above. Most kids have thresholds. Thresholds are the lowest sound that a child can hear or a person can hear 50% of the time. And usually you want that really above 15 to have maximum access. So a minimal loss might be, around 20 to 25. But if you were to do the bone conduction testing where you put the bone oscillator behind the child's ear, you might get a threshold of 0. And so even though they have an air conduction threshold, like when you put the headphones on of 20 and you put the bone conduction on and it's 0, we know that's still a hearing challenge for that child, especially a young child. So this child is a real child in Vermont. She's had a progressive hearing loss, and she now, as you can see, is in the severe to profound range for both her ears. So the X is the left ear, the O is the right ear, and that little arrow pointing down means there was no measurable to the maximum amount of the audiometer to measure above 2000 hertz for this child. And so sometimes people think, well, just put a hearing aid on her, and let's bring her up to that speech banana. So that yellow shaded area is what we call the speech banana. That's where all the speech sounds are. And so we know that normal conversation is around 50 decibels. So if you look at the loudness side, the left side of the graph, you'll see 50. We know that that's about normal conversation. And so this child, she's really struggling to hear. And even with her hearing aids on, they did some speech testing and they put her hearing aids on and they found out that she could only repeat words with 44% accuracy with her hearing aids. So that's just a reminder too, that there's a lot of distortion. So this child, it's not just a loss of volume, even though she's wearing hearing aids. When you see kids walking around school, or maybe there aren't many, it's a low incidence disability, that she's got hearing aids on, but that doesn't necessarily mean that she has access to speech. What about when hearing comes and goes? We know that kids get middle ear infection, they have fluid, they get fluid behind their eardrum. Sometimes it's infected, sometimes it's not. 1 out of every 5 children suffer from middle ear infections. Or middle ear fluid, and the average hearing loss is about 25 decibels. So when we looked at that graph, you're looking at air conduction at about 25 decibels. And thicker fluid can cause up to a 45 decibel. It's kind of the level of conversational speech. They can just barely detect sound. We hope that they grow out of this by 8 to 10 years old or sooner when there's middle ear issues. Then there's also the issue of combined vision and hearing loss. We call this dual sensory impairment or deafblind. It's not really, deafness and blindness separate that we put together. It actually creates a bigger challenge. And so these kids really need special services. There's the New England Consortium on Deaf Blindness. There's our program. We offer services for deaf and hard of hearing kids in the outreach program at UVM-MC. There's the Vermont Association for the Blind and Visually Impaired, and the Vermont I-Team has Early Intervention Project that also helps children. It's really important to know too that in order to be on the deaf-blind census, the child doesn't have to have profound hearing loss and significant vision impairment. It can be any amount of hearing, unilateral, bilateral, mild, moderate, conductive, sensory neural, auditory neuropathy. And the same with vision. It doesn't have to be, legally blind. So anytime you have a child that has dual sensory challenges, it's really important they get on the deaf-blind census. And you want to make sure you let Tracy Luiselli know about those kids so that the school and the family can get services. So hearing loss is really, how does this impact our kids, our families, teachers? It's really an access issue. So we kind of consider the ears as a doorway to the brain. It prevents or reduces access to spoken language, which all other kids have, right? Kids that have typical hearing, they have full access. Auditory access, visual access, and language access is extremely important. If they don't have full access to language, we know that learning problems happen. So there's language access. Kids that have hearing loss, even with hearing aids, sometimes they don't have enough access, right? The hearing aids are assistive, they're not corrective, even if they have a hearing assistive technology device or FMDM system. So sometimes sign language is really important for that child. Sometimes that child needs sign language and listening and spoken language. So access denied is opportunity denied. We want to make sure that our kids have access to language, that they have access, they're able to develop language, which is extremely important for literacy and school success. Some states in their ed codes have that it's essential that kids with hearing loss or deaf have an education where their communication mode is respected, utilized, and that it's developed for appropriate level of proficiency. And they also state that people that work with kids that are deaf, hard of hearing, or deaf-blind have specialized training so they understand these unique needs. Vermont doesn't have specific language to this, but it is in many, many other states. This actually, the impact of hearing loss is on the Vermont State Hearing Screening Referral Letter. And so this is this is kind of interesting to me because this really focuses on a mild or minimal loss, which I think is just great. A lot of people hear minimal or mild and they discount this challenge for the child. So a temporary hearing loss, they can miss crucial instructions during critical period of language acquisition. So I'm working with a little guy who's had chronic ear infections for a year, and it's fatiguing, it's tiring for him, and it's starting to affect his reading development. And that's just kind of a temporary, we hope it's going to get better by the time he's 8 or 10. Parents may not even be aware of a mild hearing loss, or teachers. Sometimes these kids look like they're just sort of inattentive. They're not really paying attention. Maybe they're considered a behavior problem. It's hard to tell sometimes. It's kind of a silent challenge. They learn not to rely on their auditory sense, and so they're busy doing other things. It may interfere with learning new vocabulary. It's kind of invisible. They can be, it says here, blamed for not paying attention. And it also could mean that there is a medical problem. You want to rule out a medical problem. Is there ear disease? Is there a bead in their ear? I had one little guy that had a really big bead in their ear. And a lot of kids miss a grade. They get held back for unilateral hearing loss, or just a mild loss. They might be 1 or 2 years delayed. There's some more information about impact. So one of the biggest problems about kids trying to learn language in school when they don't have typical hearing is that there's a lot of background noise, right? And there's distance. So the teacher's across the room and there's a lot of kids talking, and all noise isn't created equally. So, the ruffling of papers is one kind of noise, but also kids all talking at the same time. We kind of call that multi-talker babble. It's harder for kids with hearing loss to understand what the teacher's saying when there's a lot of other kids that are talking. And schools just have all of these problems. So it's an environment that really access is affected. They have a hard time with, distance speech. Other kids and, peers, they talk kind of softly from across the room. And so even, more so than teachers. So a lot of times these kids with hearing challenges, they miss what their peers are saying. And that's really important. It's important for them. They learn a lot from each other. They might miss bits and pieces like word endings and plurals. Words that have like past, this and the t are high frequency. They're not voice sounds. If there's a lot of noise going on, or even if there's not a lot of noise, even if the child's wearing hearing aids, those high frequencies are difficult for those hearing aids to reach. There was, figurative language, possessives, abstract language concepts. And then there's a big social impact. So the American Academy of Pediatrics had a journal out, I think 2 years ago, that had several research articles on the impact for just social pragmatics. These kids are missing incidents, they're missing incidental learning, what someone is saying. And one little girl told me, she said, sometimes I say, what, or can you repeat that? And my friends say, oh, never mind. And she said, it makes me really sad because I really want to know what they're saying. And so that happens over and over again. And a lot of times these kids kind of shut down. Some kids shut down, and then other kids go the opposite route where they want to dominate the conversation because it's easier to follow along auditorily if they're in charge of the topic. It can affect their articulation, speech sound production, their understanding of speech, and reading comprehension, which is, heavily dependent on background knowledge and semantics or a vocabulary base. So more difficulties, again, understanding speech and background noise. Localization is another thing we haven't really talked about yet. Where is the sound coming from? Where is the speech coming from? So if a child, they're having a group discussion in class or maybe home for a toddler and it's dinner time and the parents are talking, it's really hard for them to tell where the voice is coming from. And there's a lot of accommodations that we're going to talk about that are important, that are implemented in schools and to help families with their kids that are struggling to hear. They might be perceived as having selective hearing when it can vary from situation to situation. They're extremely tired. There's some new research out, and even another, Vanderbilt has put out a listening fatigue scale. And they find that kids with hearing loss actually are more fatigued than kids with other kinds of health problems in school. This is cute. Trying harder to listen and understand drains me and makes me feel down. So this is a child with hearing loss. They also may look inattentive. A lot of times they get diagnosed with ADHD. I worked with a little guy who he had meningitis, and he was diagnosed with autism, and he actually had severe to profound hearing loss, and it just wasn't picked up. He was in the foster care system, and he just didn't make it back to the audiologist. And so he went through school for 2 years with an autism diagnosis. And it was pretty remarkable when he got hearing aids, how, improved his social communication became. So listening fatigue, it really does affect kids. They're trying to, decipher what's happening throughout their day. So here's a little example. If a child had a 25 decibel hearing loss, this might be something that they're listening to in their kindergarten class. It's kind of an illustration of what their hearing ability and how it could affect their speech perception and understanding. So one upon a time, a itty mow went to vit a untry mow. The untry mow live in a field. E was lad to she high zitty friend. A two my ran about a field and lay unt new. So it's pretty hard to figure out. Did anyone know what story this is? Any guesses? I can't see the chat, so, there's one. Yeah, country mouse.
Country mouse.
Mm-hmm. Yeah, country mouse, city mouse, right? So, it might have been helpful if, so what the story, what that sentence, what that paragraph is, once upon a time, a city mouse went to visit a country mouse. The country mouse lived in a field. He was glad to see his city friend. The two mice ran about the field and played until noon. So it might have been helpful if I told you this story is the country mouse and the city mouse. And it may have, given you a heads up a little bit about what this was about. And so imagine what it's like for a child who is learning in school and learning language and just doing this all day long. They have to fill in. And what happens is they get sleepy. Sometimes they're sleepy in the morning, they're falling asleep on the way home from school. They might look inattentive. They may have difficulty concentrating on their work. They may give up easily as the tasks become more difficult. They might have a low frustration tolerance level, mood changes, and they may just have a decrease in stamina. So this is something that a deaf adult said. Many people don't realize how exhausting listening, concentrating, filling in gaps, guessing the subject, and deciphering body language, lip patterns, and facial expressions is. So imagine, being an adult and having that challenge, and then we have these kids sitting in school with that challenge. Listening is really hard work.
So Tracy, there's a question. Why is hearing loss in the right ear have more of an impact?
So the right ear tends to have more of a dominance than the left ear. And so that is true. And if there's a progression to, if it progresses more in the right ear than the left ear, it can have more of an impact on speech perception. So what's really important is to find out how that right ear disadvantage might be affecting the child in a functional learning environment. So there's a functional listening evaluation that an educational audiologist or a speech language pathologist, a teacher of the deaf could do, or a special educator, to really look at how that child is doing with a right-sided hearing loss, whether it's mild, moderate, severe, profound. If it's profound, it's single-sided deafness is difficult in both ears, but if there's a different type of hearing loss, the right ear has more of an impact. So by 5 years of age, children need at least 20,000 hours of language access to be ready to read. So 20,000 hours. So there's a device called Lena, and it's a device that parents wear at home, and it kind of calculated, we came up with some data about different situations that increase or decrease access to vocabulary. And there's some different variables. But if we have a child with hearing loss, they don't have access to language, right? They need 20,000 hours of language access to be ready to read. So when we talk about kindergarten readiness, it's really important to make sure if you have a child that's born and identified by newborn hearing screening as having, profound hearing loss, we're going to talk more about this, but it's really important that they have early intervention so that we can reach those targets. So there's communication choice. If a child's born in Vermont and across the country, it's up to the early intervention team to share different communication choices. And then it's up to the family and the child to figure out what communication choice is going to work best for their child. They could be bilingual. They can use sign language and spoken English, sign supported English. They can use listening and spoken language only, cued speech, protactile sign language, and total communication. In 2019, the National Association of State Directors of Special Education came out with, we call it the Purple Book. It's a really amazing document optimizing outcomes for students who are deaf or hard of hearing. And it's an educational services guide. And this really is a spectacular guide. And in Vermont, the Agency of Education is really working to make sure that the schools understand sort of what is in this guide and really help support implementing all 10 principles that are in this document. So the 10 principles, I kind of listed them here, that each student is unique. We have high expectations that drive educational programming and future employment opportunities. That families are critical partners. Early language development is critical to cognition and literacy, academic achievement. That we're very individualized for designated instruction. We use least restrictive environment, and least restrictive environment doesn't necessarily mean that these kids are mainstreamed. For kids using ASL, sometimes least restrictive environment is in a school for the deaf. So, you want to think about that a lot when you're considering kids who are deaf and hard of hearing. Educational progress has to be really monitored for these kids. They tend to have kind of like a subtest scatter. So it's not like there's a delay, but they tend to have pockets of difficulties. So it's really important that these kids have an assessment. If you get an audiology report at school, you want to look at that audiogram and get some information from that. But it's also really important that the kids are assessed for their strengths and weaknesses and how they learn best at school, given their unique hearing loss or hearing challenge. It's also very important that they have access to peers and adults who are also deaf and hard of hearing. So a lot of times kids think that they're going to grow out of it. They'll ask me, they'll say, Tracy, when will I not have to have my hearing aids anymore? Because they tend to be the only child in their school that has hearing aids or a cochlear implant, or maybe there's one other child that is wearing devices. And they may have never met an adult that has hearing aids or a cochlear implant. Most kids that are born deaf and hard of hearing are born to hearing parents. So it's important that the different programs provide opportunities for kids to meet other kids and adults that also wear hearing aids and have hearing challenges or use ASL. Another important part of this is qualified providers are really critical to the child's success. It's a low incidence disability, so schools aren't typically hiring an educational audiologist or a teacher of the deaf because there's probably only a couple of kids in their school. So we'll talk about the two primary programs in Vermont that receive funding through the Agency of Education and what services are available for students, but also for school teams, because the CCC-A CARES program, they offer technical assistance and consultation to the school team staff. And then the deaf and hard of hearing, deafblind outreach educational services program at the medical center has more specific service providers, licensed teachers of the deaf, audiologists, speech language pathologists, and interpreters. And then also that there's a state leadership and collaboration, that it's important we all work together to make sure that these kids get their needs met. So what is an educational audiologist? What's the difference? A lot of times there aren't enough educational audiologists. And so a lot of the times the schools rely on the clinical audiologists. And I adore our clinical audiology partners. We really have to work together. But in educational audiology, there's just, it's just a different field. So in the clinic, they're really making sure they diagnose the kids, that they get an ENT clearance to wear technology if they need, find out if they're a cochlear implant candidate. And then when they get into the school, what is their listening environment? What other equipment might they need in noise and distance in their school setting? What are the acoustics like in the classroom? What is the signal to noise ratio? The teacher's voice over ambient noise. And so an educational audiologist is an important partner in this team. And then a teacher of the deaf and hard of hearing, an interpreter if the child uses sign language. So it lists a lot of different professionals in the Purple Book, and educational audiologist is one of them. So on an IEP, oftentimes you'll see that kids have speech therapy and maybe OT, and those are related services. Audiology is also a related service, and a lot of people don't know that, but it's the same as speech, OT, PT, orientation and mobility. And even nursing services, right, are a related service. Is that right? Anybody? Is nursing a related service or a direct service on an IEP?
I believe it can be either.
Gotcha. Depending on the needs of the student. So then how does a student qualify for IEP services? This is a link to the document that shares this. So what is a significant hearing loss according to the Vermont guide or board rules when it comes to IEP eligibility under the category of hearing loss? Hearing loss means an impairment in hearing as determined by an audiologist, otologist, or otolaryngologist, and demonstrated by a 25 decibel hearing loss threshold or worse for one or more of the frequencies 250 to 8,000 hertz in one or both ears with or without amplification. So 25 dB, like we talked about, that's kind of considered minimal according to some ENTs, but it is considered hearing loss in education. And something interesting that Vermont did is in IDEA regs, they separate deaf and hard of hearing. And in Vermont, they grouped the eligibility together as just hearing loss. So what about technology and accommodations? There's all kinds of different technology that help support children that want to use listening and spoken language as their method of communication. There's hearing aids, which look a lot, different than they used to. There's two primary manufacturers that dispense pediatric hearing aids. That's Oticon and Phonak. Are the primary hearing aid companies that the medical center dispenses to kids. There's some other companies too, Widex, but primarily we use Oticon and Phonak. And the little boy up in the left-hand corner, he has an ear mold. That's what's keeping his hearing aid in his ear. And sound comes into the hearing aid and it's amplified as it's programmed so that it's amplified to the frequencies that that child needs. Hearing aids also have a special function these days. They're like Bluetooth compatible. They can connect to an iPad or a phone, which is really fun for kids. You can get different color ear molds and different color hooks to make it interesting. A lot of the times the programming, it's important if you have a student that has hearing aids at school that your team knows how those hearing aids are set. So does that volume control work? Because sometimes the audiologist, the clinical audiologist can disable that volume control. So you don't really know if it works, or there's a program button. So you want to know how those are set. And then the ear molds need to be changed and updated about every 6 to 12 months because the kids' ears change and the kids grow. And so they need new ear molds. If they don't get new ear molds, sometimes the tubing can get cracked and it can break and it can come out, and that affects the child's ability to hear at school and at home. So it's important that if the family needs support getting to the audiologist to have new ear molds made, that there's support for them in that. And then in the bottom, like I said, they come in different colors and ear hooks. And there's also another way that hearing aids are retained in the child's ear. It's called like a dome and a tube or a wire. And so it's some kids like it. It's a little more cosmetically appealing. And it also allows more normal like air to come in through the ear canal, and some maybe low frequency sounds. So there are different ways for kids to wear this type of hearing aid. It's called a BTE, behind the ear. Most kids have BTEs because we don't want to put anything hard in their ear canal. If they were to fall, they're busy, they're climbing, they have PE, they have sports, it could break and damage their ear. And also when you have in the ear type hearing aids or harder type acrylic molds, their kids' ears are changing shape so rapidly that it's very expensive to try to replace the hearing aid, whereas an ear mold, it's much easier to replace. And then there's another hearing aid called a BAHA, or bone anchored hearing aid. This type of hearing aid is mostly used for kids that have conductive hearing loss. So it's a bone conduction type hearing aid. Cochlear, the company Cochlear, they kind of call their hearing aid the BAHA 6, BAHA 5, but BAHA really stands for bone anchored hearing aid, and there is a couple primary companies that dispense those to kids. So the sound processor picks up sound vibrations from the environment around you, and it translates them into, so it picks up the sound and then it turns them into little vibrations, so it transmits sound. So if a child has a hole in their eardrum, if they have abnormal ossicular chains, those little bones, then they might have a bone anchored hearing aid. When a child has a bone anchored hearing aid, sometimes they wear it on a band, as you can see this girl is, until they're about 5 or 6, they're not surgical candidates. There are surgical options for different kinds of bone anchored hearing aids. Med-El has another kind of bone anchored hearing aid, and so does Oticon Medical. And so, each child is different. Each medical facility that dispenses these devices has criteria for, what they're dispensing. And most of the time, they give the family options and the student options of what's available, the functionality of that device, and then they can choose it. One of the drawbacks to having this type of hearing aid on a soft band is it's not very good with the high frequencies. So the kids get pretty good low and mid frequencies and some of the highs, but about 4,000 hertz, it kind of rolls off. And we know 4,000 hertz is important for, word endings and plurals. So that's kind of why it evolved into more of a surgical option. So they can put like a little, abutment is what they call it, into the bone, and then the hearing aid hooks onto the abutment. And again, we want to know how, at school, if you're the case manager for a child that has a bone anchored hearing aid or any kind of hearing aid or cochlear implant, you really want to know how that device is set so that the child can learn, how it's set. Someone should be working with the child too on their equipment and how it works so that they're really advocating, they have good self-advocacy. And there's a whole curriculum out there for self-advocacy for kids that are deaf and hard of hearing. And then on the bottom, those are some cochlear implants. So a cochlear implant is a surgically implanted device for children that mostly have severe to profound hearing loss. Candidacy for cochlear implants has really evolved. So it used to be, both ears had to be severe to profound. The FDA is passed now, so single-sided deafness can be implanted. And there's also some hybrid implants now where they try to preserve the low frequencies and only implant the highs. So if you remember from that video, it said that it's kind of tonotopic, the cochlea. So one end is more the low frequencies, which is the apex, and then the lower frequencies are in the basal section of the cochlea. So what they try to do when they put that implant into the cochlea is preserve the low frequencies and just implant the highs. With cochlear implants, it's really important to know that, it's not a transplant. It's not like they're putting a new cochlea in the child's ear. With all types of hearing devices, kids really should have services to support them learning to listen through their devices because it's not corrective. It's just assistive. The other thing that happens in schools is the FM system. I always think of FM system as like, a lot of people say FM system, it's kind of like Kleenex, but most remote microphone systems are not frequency modulated anymore, which is what FM stands for. So I like to use hearing assistive technology, and that's kind of the new term is hearing assistive technology.
There is a question in the chat box about your previous slide asking, is research being done to help find solutions for high frequency hearing loss?
So yeah, that's a great question. So the hearing aids are much better than they used to be with high frequencies. So they have something called, I clicked on, there we go. They have something called like sound recover. So the hearing aid is able to take some of the low frequencies and kind of squish things together to improve high frequency access. Oticon, different manufacturers explain their technology, and it's kind of, proprietary, like it's kind of a secret. So we don't really know, but my understanding is Oticon hearing aids, they have a larger frequency bandwidth than Phonak, but Phonak claims that they have higher fidelity. So when I started in this field a long time ago, we wouldn't put hearing aids on people or kids that had high frequency hearing loss. They had to have a loss at 2000 hertz. And now we really are amplifying. We're at least giving a trial period. So for any child or adult that wants to try amplification, there is a federal requirement that you can try these devices and see if they benefit you. And so there are hearing aids now that really do specialize in high frequencies. The Baja on the soft band just has that limitation. They haven't improved it yet. Bone conduction is kind of tricky in how it's able to transmit sound. So the high frequencies kind of suffer in that regard. But when they do an abutment, when they're able to do surgery, the high frequencies transmit better. I think the soft band, it just has something to do with like the thickness of the skull and that little device being able to transmit sound into vibrations to reach those high frequencies. That's just my understanding. So for hearing assistive technology, a lot of times it's noisy in the classroom. We talked a little bit about that. We really want the signal to noise ratio in the classroom to be at least plus 15. And what that means is the teacher's voice needs to be about 15 decibels above the ambient noise in the classroom. And so sometimes I go to classrooms with my little sound level meter and I take measurements and I try to figure out, how loud is it? Is the teacher's voice reaching that child and where that child's sitting? So I collect some data, and that helps support the purchase of remote microphones or hearing assistive technology. So it often means that the teacher's wearing a microphone, and then there's usually a wireless receiver that goes onto the child's hearing aid. And now they've gotten so sophisticated, it wasn't that long ago that you had to put a boot or a shoe onto the child's hearing aid and then take it off at the end of the day. And now the companies have come out with better systems where we're downloading the data into the hearing aid for the receiver. So it's really important to consider hearing assistive technology as part of any IEP. And also, I think it's important for kids that are on 504s or kids that have hearing technology at school to find out, do they need any other devices? So in this little transmitter box, you see there's a primary transmitter, which is the Roger touchscreen, which is in the middle. And that's maybe something the teacher wears. The touch screen now is so smart. You can lay it flat and it acts as a conference mic. And then they also have a pass mic. So in order to really make sure that child has direct access to peer input, questions, comments, the teacher may want to repeat those into the microphone, but then also it's important that the kids actually talk directly to the student. And then that other little box on the right is called a multimedia hub. A lot of times teachers now are teaching off of the smartboard, and they have, videos, or they have, lists of things. And so we want the teacher to be able to talk to the student. We want peers in the classroom to be able to talk directly to the student. And then we want that student to have access to what's coming out of the multimedia. So again, it's just really important that you have someone that understands the unique needs of the child on their team, whether it's a 504 team or an IEP team. And that all these options are considered for them, and the team decides what they need. And I'm not saying that all the kids need all of these components of a HAT system, but it's important that you know what's available and can make sure that child has as much access and reach their potential as possible. So here's some data. I think this is from Boys Town. Children need to wear their hearing devices during all waking hours. So kind of the magic number is at least 10 hours. And there was a study with their grammar skills. And their grammar skills were with full-time use of their devices. It was almost close to kids with normal hearing that were wearing their devices all waking hours. So here's some more about accommodations. What can we do? So aside from technology, what else can we do to support the kids in their home environment, at school? Strategic seating. So preferential seating doesn't necessarily mean front and center. We want to be strategic. Which ear is their better ear? Do they have a better ear? Where is the HVAC, right? Even if the front you think might be a good place for them to sit, but the HVAC is right there, it may not be because it's too noisy. Maybe the door to the classroom is left open because of COVID. We have to have the doors open and there's hall noise. So really think about where that child should sit in order to have maximum access. Usually sitting towards the front and off to one side is a good place to start. And also it's best to have the classrooms configured in a U shape. So if it's in a U shape, that tends to give the kids better access and visual access to peers and their teacher. Try to repeat what other kids say as much as possible, especially into the microphone. Discussions happen really fast, right? In classrooms, kids are speaking fast, and that rate, along with having trouble localizing, right, which was what we talked about, they have hearing challenges, having trouble localizing and knowing where the person's speaking from or who's speaking. It's important for the teacher to have some strategies like calling out the person who's talking's name so the child with hearing challenges can hear that. Make sure you use consistent use of the technology. We just talked about that. Face kids while talking. These are things that can be written into a 504 plan under the accommodations or an IEP. Capture, you want to use attention getting strategies. Sometimes I see teachers use this like tiny little bell, and I think that's really great if the child has normal hearing, but the tiny little bell might not help this little person with hearing challenges. Closed captioning is very important, even for kids that are learning to read. There's some research out there that having the captioning on can be really helpful and showing any kind of multimedia. Provide visual supports, making sure there's outlines, written examples. Make sure that you're giving directions once all the kids are in the class. I was at a school once and the teacher was giving directions about what was happening next as the kids were coming into the room. And so the kids in the hall, and one of them had hearing challenges, sort of missed all of that. When using overhead visual supports, make sure that the teacher isn't talking while their back is turned and while the kids are maybe copying off the board, so that there's just one thing happening at a time. And then classroom acoustics. What can you do to improve the acoustics in a classroom? Just be aware of the noise sources. You can put rugs and stuff and tennis balls onto the bottom of the chair pads. Sound absorbing materials, and then just make sure that you are just closer to the student. So you want to use a typical rate and volume when you're talking to kids with hearing challenges. But you just want to be a little bit closer to them so they have better access. When everyone was wearing masks, the masks were a high frequency filter. So it really gave everybody a hearing loss. And I think a lot of people realized how hard it is for some of these kids with mild or minimal hearing loss to get through the day, just how fatiguing it can be. Here's a video about lip reading. I include this video. It is about 4 or 5 minutes long. But I wanted to play it because I think it really has an impact. I hear a lot of teachers and just people in the community saying, well, she does really well. She can lip read really, really well. And so I think she's fine without her hearing aids. She can just lip read.
So when I was really young, probably kindergarten or first grade, I have a much older brother, and we'd go out to recess, and there was this older guy, he might have been in like 5th or 6th grade, that always used to pick on us, and I didn't really know what to do about it.
Today we went to a high school and I
was posing for a picture with all of my girlfriends. And all of a sudden, one of them reached over.
Can you read my lips?
And
Can
you read?
Can you read my lips? Can you read her lips?
Oh my God, Clementine loves bread. She stole a loaf off the counter.
Can you read his lips?
I have two dogs, one boxer, she's 7.5.
I am deaf, but my word. What is a hearing one? I rely on the visual, not the auditory. The word lip reading implies reading, like reading a book
whose text is legible and clear.
But the human face isn't a book, and lip reading isn't reading. People mumble, people talk fast enough loudly, people have facial hair like porcupines, lips like sphincters, people cover their mouths, people have accents. But real conversations don't take place in the studio. Grown up. Putting together a puzzle without all the pieces. I look in on your mouth. I try to grasp with one sense information intended for another. There have been times when I've questioned why I even tried to breathe. The way through the spawn. But I could just use sign language. Some deaf people choose to do just that. It's like a different word. A word filled with rich expression and culture. When people sound, they come alive. But I know I want both words. Communication is never a given.
Tuesday, I woke up, had a rash.
She just pulled my dress down.
When I was little, my family got a cat.
Like, why don't you just hit him in the face? That was like the last thing that I ever.
When I learned to speak, I only cried twice.
But when the reading works, when I focus on one nurtured face and launch into a conversation, something clicks. Right then, I feel something extraordinary. Human connection.
So I think it's kind of impactful, you know, as an audiologist and a speech language pathologist, I think I certainly have my biases, right, on, you know, should all children learn listening and spoken language? We have cochlear implants. And I, you know, being in this field for almost 30 years, I just want kids to have communication and effective communication and the challenges they face. You know, in Vermont, the Brattleboro School for the Deaf closed, the Austin School for the Deaf closed, and there aren't, you know, our kids are mainstreamed, whether they're using listening and spoken language or have technology. And I think it's just really important to you know, be open-minded and to just to make sure that the kids know what their options are to access their curriculum, their education and communication. So hearing conservation, this is also just a really, you know, important thing. I don't think kids realize that they can lose their hearing if they constantly have earbuds in their ears at the high school, which I see all the time. They're oftentimes they have wireless earphones, And so a lot of kids say, well, if I lose more hearing, I was at a school the other day, a high school, and I was in their vocational career center, and the child has a hearing loss on one ear and then fluctuating hearing loss on the other side. He said, I know I don't want to, if I lose more hearing on my other side, I'll just get another hearing aid. So I think it's important that the kids learn that they can lose more hearing. I think there should be programs in schools to make sure that like construction doesn't happen during the school day, and that there are opportunities as part of health education that as part of the health education curriculum that hearing conservation is addressed in the schools. I was at a show, and it was for elementary school kids, and they had the kindergartners sitting right close to the band. And I was in the back of the auditorium, and I had my sound level meter, and it was like reaching the maximum of the sound level meter. It was maxing out at 100, and I'm sure it was much louder. So very well, we could have harmed someone's hearing in that environment. An estimated 12.5% of children and adolescents ages 6 to 19 have suffered permanent damage to their hearing from noise exposure. 1 in 6 adolescents has a high frequency hearing loss. And this is kind of what happened, I think, with hearing screenings in 2017 in Vermont, where they found it was really important to start assessing your middle and high school kids for high frequency hearing loss. So this is what happens to the hair cells when there's noise induced loss, right? They look pretty destroyed from normal to noise induced, and noise affects the high frequencies. So here's a link about what you can do in your school if you want to implement a hearing conservation program, if you don't have one already. I don't think it would be hard or time consuming. I think it would, could be, pretty seamlessly integrated into other health programs you have at the school. Although I know the pandemic has, changed a lot of how much time you have to do those things. So here we are at hearing screening. How do we find out when kids have hearing problems in school? Oftentimes, you have your regular interval hearing screenings that you do. A lot of the times I hear, well, they passed their newborn hearing screening, so I'm sure they're fine. But we've learned a lot about incidence. The incidence of permanent hearing loss doubles between birth and school age, and then it's up over 14% below the age of 15. So about 2 or 3 kids out of 1,000 are born with hearing loss. And again, that doubles. So that's why we screen. Why is there hearing loss? After the newborns are screened, there's a lot of acquired hearing challenges that happen. We talked a lot about middle ear pathology. CMV is a real culprit. There's progressive congenital hearing loss, meningitis, trauma, chemotherapy, and syndromes. One of the most highly predictive criteria for identifying a child with hearing loss is the teacher concern for hearing, speech, or language delay. So we really want to listen to our teachers when they have a concern about a child's speech, language, or hearing, and make sure they get a hearing screen. I'm always amazed at kids that get into speech therapy in school and they haven't had a hearing screening. I worked with a little guy who had speech delay. And when I started working with him, he just was kind of saying, huh, and he didn't seem very attentive. And so I asked the nurse if he had passed the hearing screening. And I asked the parents, and she said, at the hospital, they always say it's behavior, that he just can't, it's just his behavior. He's being silly, he's shy. And then the school nurse said the same thing. So I did play audiometry at the school, which he was very compliant in, and he had a cholesteatoma. He had a pretty significant bilateral hearing loss from really thick purus fluid, and it wasn't really infected. He just had this thick glue fluid in his ears. And it ended up being a cholesteatoma, and he had surgery. So yeah, it's really important to do those screenings and to follow the protocol. I was at another school and they had a lot of volunteers doing the hearing screenings, and it's hard. Everyone is so busy and people think it's just not really that important. It's a low incidence challenge, but it can have such an impact. So you just want to make sure that you have a plan for your volunteers, make sure they have training. And honestly, if the child can't condition to the task, they should be referred for a full full audiological evaluation. They should have a hearing screening before their annual 504, and certainly at least at the triennial for the IEP and initial referral for special education. Signs for parents to watch for if they think their child might have a hearing loss, or what you might look at school. If there's any concerns, they don't respond correctly. Their teachers are asking questions and they're answering kind of off the beaten path. Speech and language concerns, they kind of watch closely, turn up the TV. Difficulty understanding other people on the phone, although kids don't talk on the phone anymore, they text. So complaints of ear pain, poor academics, ear infection, head trauma, meningitis, concern, ototoxic medications, and noise exposure. So what's the difference between a screening and an evaluation? I'm sure you know this. This is just a screening. It's a pass refer. There's some controversy about using pass fail. So I try to just use pass refer instead of pass fail. And if they don't pass the screening, they should go to a full diagnostic audiological evaluation, preferably with a pediatric audiologist. They need to figure out the type of hearing loss, the degree, the severity, and also the etiology, what might have caused it. And also treatment options, right? We want to address it. We just learned all about that. So in 1999, they passed universal newborn hearing screening, and it's really made a big difference. They used to only diagnose about 2,000 babies, and now they diagnose close to 6,000 babies with permanent hearing loss. And there's the 136 rule. So if they don't pass newborn hearing screening by 1 month, they have a diagnostic. By 3 months, they're fit with hearing aids amplification. And by 6 months, they are enrolled in early intervention. And how do we do all this? Is all of us together, the hospitals, midwives, primary care providers, audiologists, early Head Start programs, and you are doing these screenings. Why was the child's hearing loss not caught at birth? So we talked a little bit about this. We know it doubles before they get to kindergarten. So we have this group of kids, about 2 to 3 kids out of 1,000 that are diagnosed with hearing loss at birth. There is a database that you can find out if a child has passed their hearing screening through the EDI program. And I think that's important to talk to the parents or get the medical information to see if they did pass or didn't pass. And then if they have any risk factors. So a lot of risk factors, they have to be rescreened before a certain age. Like if they were exposed to ototoxic medications, if they had CMV. So a lot of the reason that these kids weren't identified at birth is if they have late onset progressive hearing loss to follow-up. Sometimes, especially during COVID, we're finding that, parents just didn't want to bring their newborns back to the hospital for a diagnostic. Can be acquired from medications, infections, syndromes, middle ear. And then sometimes it just wasn't detected in newborn hearing screening because it could be mild. And so it kind of depends what screening they do. So there's, for babies, obviously they can't raise their little hand and tell you they heard the beep. So there's otoacoustic emissions and there's ABR, auditory brainstem response tests. And so there's limitations to those tests. So I just worked with a 4th grader who has a mild sensory neural hearing loss. And he has, it said that he passed newborn hearing screening and it was an ABR. And he's been going to ENT with middle ear problems, and they kind of assumed it was middle ear. And it turns out that it's not middle ear. He has a permanent bilateral sensory neural hearing loss that wasn't picked up by the newborn hearing screening. So again, it's just good to keep screening these kids.
There's just a question in the chat. How do you access the program to see if the newborn had hearing loss? The program that you were just talking about, you can look them up.
Yeah, so I would ask the parents first and the medical home what the status of the hearing screening is. So I think the medical home the EDI website has a database, and the medical home can look up on the database where the baby was born, this is all just for Vermont. So what hospital they were born at, if they passed the hearing screening, which screening they passed, OAE, ABR, or both. And then if they had any risk factors, so they needed a follow-up, and then what the outcome of the diagnostic was.
Okay. So accessing that would be partnering with the primary care provider or talking to the parents.
Or the audiologist, yeah, or talking to the parents. Yeah, and you can ask me too. Feel free to email me. I'll try to find out more about who has access to that database, but I thought anyone in the medical home, the audiologist, the primary care should be able to look and see if they pass newborn hearing screening. So there's a list of high risk factors of kids that need to be rescreened. And I think in the preschools, it would be really good to know that if those kids did have, oh, what a cute dog. Sorry, I had to say that. I have 14 pets, right? I locked them all upstairs. None of them were on the call. Syndromes, if they were in the NICU, prematurity, ototoxic medications like gentamicin, ampicillin, HIV, syphilis, CMV. So all those kids are at a risk and should be rescreened. So for school age kids, so according to the American Academy of Audiology, there's no like single federal mandate for hearing screenings. However, IDEA in 2004 requires school districts, as part of Child Find, identify kids, locate them, and evaluate them with disabilities. And Vermont, this is why we should be doing hearing screenings in Vermont, but Vermont has criteria and mandates for doing screenings. Why should we do them in schools? Because there's a whole bunch of kids there all ready for it. It can be accomplished in a short amount of time. It's a lot less expensive than trying to get it in another part of the healthcare system. It also allows like ongoing opportunity to kind of look at those kids. Like if they didn't pass, like they were nervous, you can take them back the next day and try again. And then also screen kids who haven't been previously identified. So here are the Vermont standards. So I think you're going to have access to these slides and the links in here, but there's this neat little book, the Vermont Standards of Practice, School Health Services. I'm sure you all know about this book and know it by heart. Section 16 has kind of the health appraisal section, and then section 26 is the screening. So it gives you just like all the steps of implementing, developing, and evaluating the health services at your school. I thought it was really cool that they have like a sample planning calendar in there and timelines. If the volunteers are used, they have guidelines about, how to review confidentiality rules. And then it's just recommended that you start screening in October and continue out through April, and may begin the follow-up. So typically the Vermont standards recommend performing the screenings at 1,000, 2,000, and 4,000 hertz. And then in 2017, they added 6 and 8 for our adolescent kiddos. Some people like to do 500. I like 500 also, because when you're testing 500 hertz, you're really looking at a possibility of a mild low frequency loss, which is typically middle ear pathology. So if it's the middle of winter and you have a kid in special ed or they're going to speech and you're screening their hearing, if you test 500 hertz, you're in a nice quiet room, you might find that the child does have a mild or minimal hearing loss that may be conducted from fluid, but that isn't in the guidelines in Vermont. They suggest 1, 2, and 4. If they don't pass the first time, reposition the earphones. If they don't respond at 20 dB, you want to make sure you're in a quiet environment. You do it at 20 dB at all the frequencies, and they either hear it or they don't. And that is the screening. So the sensitivity of doing the adolescents, it really improves identification of children with hearing loss. And that's why it was added in Vermont. So the criteria is to pass at 20 dB at all 3 frequencies in both ears. Refer is if there's no response at 1 or more of the frequencies. And repeat it within a month, not sooner than 2 weeks if they fail the initial screening. I should have written refer. I'm trying not to use fail. So if they fail, what do you do? So Becca was sharing that sometimes it's really hard to follow up. The parents don't go back. There isn't a great system for follow up. I really suggest that you do follow up and make sure that these kids do pass a hearing screening. And I know sometimes it's hard, but you can collaborate with the medical home to determine, what to do if they aren't following through. Make sure you get the clearances that you need. The referral letter might have information about Vermont Health Connect, and I put the resources in there, provider recommendations, and then screening results can be sent directly to the medical provider with permission. follow up with them with the screening results when the form isn't returned within a month. I have a feeling that's really hard. A month goes by really quickly, but that is what the guideline says in that Vermont guideline document. Assist with the barriers. So if they're having trouble getting into the audiologist, I realize it is really time consuming. I'm happy to help if I can. If you have a student that you're really worried about their hearing, I've helped schools try to, connect with the parents, sometimes just a phone call from someone else saying, this is really important. We're really concerned about your child's access to school. And we want to make sure that they're hearing everything. And we need to know if the high frequencies are, if they have access to the high frequencies and the low frequencies, notify in writing, and then document. These are some suggestions by the ASHA, American Speech Language and Hearing Association. Just also make sure your equipment is calibrated. It's good to check it at 10 dB for someone that has normal hearing before you do your screening day. It should be in a quiet environment, free from visual distractions. You shouldn't transfer one kind of headphones from an audiometer to another without additional calibration. So you just want to make sure your equipment's working before you do this screening. So the primary way that we test kids for a hearing screening is they raise their hand, right, if they hear the beep. Another one that I find some nurses don't know about is conditioned play audiometry. So I have a quick little video about how that works. So if they hear the beep, they put a ball in the bucket.
Does it pink in your ears? Oh, it looks beautiful. What about the other side? Can I see the other one? And that one looks pretty good too. Okay, now can you hold that on the table for me? And I want you to listen for my whistle. Are you ready to listen? There's the whistle. So now you can put the marble in the hole. That's it. Well done, Daddy. Good boy. I'm going to check that one. Look at Daddy. Good waiting. Sometimes they take a while.
It went very loud.
That was a little one. That's right. Very good.
I think that's such a cute video. But sometimes three-year-olds, they tend to not, I think, raise their hand when they hear the beep 33% more than older kids. So if you have a 3 or 4-year-old play audiometry, sometimes you get much better information. You do need to condition them first. You show them what to do. I use like a xylophone sometimes, and and I hit it and then say, oh, I heard that, and put it in. And they really think this is a fun game. You can use like the Connect 4 game, but they think it's really fun, and then you get accurate information. So they have to respond to each test frequency consistently at 20 dB for each ear. And if they don't respond in either ear, then they're referred. So what are the next steps? Any child who passes the rescreening is considered a pass. So you're done with them. Any child that doesn't pass the rescreening or does not condition properly, so you've tried just traditional audiometry, raise your hand, push the button, and you've tried play audiometry and they don't condition, they should be referred to a licensed pediatric audiologist. That's me saying that. Obviously, if they don't have a pediatric audiologist, but I do find, so our ENT clinic at UVM-MC, when the kids go there, I find oftentimes we don't get a really good hearing test sometimes at the ENT, but when they go to Fanny Allen or they go to Dartmouth and they see the pediatric team, we get better information. So I think it's just having the right toys and having a test assistant that really can make a difference for the kids, and then follow up for diagnostic testing with a licensed audiologist. So inappropriate hearing screenings in California, we had a group of, we had a lot of kids that are complex needs kids, right? You can't screen them. And so the nurses were, I think what everyone does is amazing to try to get information about what these kids have access to, but they were using the music to my ears kit where they were taking bells and ringing them and then passing them on the hearing screening. So we did a whole educational program, and we learned that it's really not effective. And it's also against guidelines set forth by ASHA. So you just don't want to use music to my ears. They're still selling it. They still have a video of how it works and how you can use it to screen kids' hearing. But I think it'd be much better to get otoacoustic emission equipment. We're going to talk a little bit about that, but I'm going to start moving through these quickly. The ear exam, otoscopy, make sure you look in the kids' ears, look for, asymmetry, low set ears, if there's a skin tag, to see, if there might be something else going on here with a syndrome. Make sure you bridge your hand. Little kids move their head, and you don't want to give them a hearing loss by putting a hole in their eardrum, or making them feel worried that, so it's always good to bridge your hand. And then internally, you want to look for a foreign object. You want to look for cone of light, redness, the handle of the malleus. And so the two kinds of screenings that happen in the NICU and then diagnostics are.
Sorry, just questions about otoscopes while you were just on otoscopes.
Yeah, sure. Let me go back.
So when we need to upgrade our otoscopes, do you have any suggestions on brand or type of otoscope? And can you speak to like the size of the specula and like what you recommend for, because there's just so many. There's like 2.5 and 3 and 3.4 and
Yeah, you want a variety because you want kind of the largest that like fits in their ear in order to be able to see well. I really like the, I can send you information. There's an otoscope that has an extra head that has a better amplification, a magnification. And I love that otoscope. I don't think it's Hen. I can't remember, but I will look it up and I will send it to Becca on which otoscope I like with the head. And as far as the specula, you need a variety because you probably screen kids 3 to 22 and they all have, I have to say, some 3-year-olds have really big ear canals and some, so you just need a variety of sizes for those.
And then just one more question about, there's a Vermont, New Hampshire district, and New Hampshire the standards are different between the two states. 25 is acceptable in New Hampshire. And so how do you approach that with families?
That's a great question. I would probably be on the side of caution and use 20 and just say, it's an interstate district. And in Vermont, we use 20. And to be honest, I would say, I know that educational audiologists really want kids to be at 15. So if they're at 25, I guess I would just, and maybe if they have any learning challenges, I would want to just rule out hearing as something that might be contributed to attention, or if there's any issues happening in school. If they're like in the gifted program and they, and they're, I don't know, I still would want to know if 25, if they're only screening at 25, they're not looking at a threshold. Is that what's happening? Oh, so like if they got.
Jane Glick had the question. Jane, why don't you unmute and can you answer Tracy's question?
Can you repeat your question?
Are they screening at only 25 or are they screening at 20 as well?
No, they're just screening at 25. Even the doctors are just screening at 25. So then when I'm sending a referral letter home or calling a parent and I'm telling them, what the results are for the 20 decibels, they're like, I don't want you screening my child, and they're fine. They pass at the doctor's office. They're good. And the other thing that's hard for me in my community is a lot of my students, their parents are doctors. And so, I'm confronted with that.
I mean, if if the parents aren't worried and the kids are passing a screening at 20 or 25 and they're giving you, a difficult time, I think it's okay to just say, okay, I mean, if they're passing at 25 and not at 20, I mean, it could just be the room that you're in, or maybe they have, negative pressure in their eustachian tube that day. But yeah, I mean, that's a hard situation. But I think 20 or 25 in a screening situation, if they're not passing at 20 and they do at 25, it's not at the end of the world, but I'd be interested over time what happened. I might just out of curiosity rescreen that child in a month and see, are they still passing at 25 and not at 20? And is it all the frequencies? Do 5, do 1, do 2, do 4, do 6, and do 8. And say, they didn't pass at 3 frequencies. And they didn't pass at 25 either at 1 frequency. I think it would be good for them to have a complete hearing test. And, if the parents acknowledge that you've done the screening and they haven't passed and they don't want to pursue it, I think you can document that. So the ABR, there's 2 kinds of screenings and there's limitations to both of them. So these are if you have kids that have complex needs, you can do an ABR or an OAE screen and just see if they pass. So you have information for the IEP. We have OAE screens in Vermont, and I have gone out and supported a team to see if they, if they have medical complications and the parents don't want to sedate them for the ABR. And like I said, there's some kind of limitations. What I love about UVM-MC is the NICU babies have to pass an ABR and an OAE in order to be considered a pass, which is great. So then we're not missing kids with auditory neuropathy. This is just kind of how the screening works. It's really quick. It takes about 30 seconds per ear. I know Soph has been doing some OAEs, and I'm curious how that's going. Definitely. So the only thing that is left was just that I have the services on the last page through CDCI CARES team. They do mostly consultation and technical assistance, and the outreach program through the medical center. We do more direct services for, we have audiologists, teachers of the deaf, and interpreters in this program. So there are services available for students. And the other suggestion I had for equipment was just that I highly recommend, if you're getting new equipment, that you reach out to the rep and have them demonstrate it for you before you pick, because it's really hard to tell and people have different preferences. So they really can come out and show you what's available for screening equipment, and then ask them for quotes and try it, get your hands on it and think about it before you purchase. Okay, any questions?
Well, while anybody's thinking about that, I will say that so 2 things right now are in the shared drive. One is the presentation, so all the links in the presentation will work. I made another sheet that has any of the videos that were in there because they won't be on that PDF. So you can still have access to those if you wanted to watch that or share it with somebody else. And there's a couple of other links that I stuck in that document, one that Allison shared, and a couple of other things that I pulled out while Tracy was talking. So you'll have those available.
And feel free to reach out to me if you have any follow-up questions or a specific student that you want to talk about. Please feel free to reach out. And thank you for inviting me to share this information. I really appreciate it and everything that you guys do out there. So thank you.
Thank you so much for coming. Amazing information and really in-depth knowledge that we don't always get. So thank you.
You're welcome.